you everyone for being here. We're just going to start off. My topic for today is metacognitive training for psychosis. The article I chose today is titled Immediate and Sustained Outcomes and Moderators Associated with Metacognitive Training for Psychosis, a Systematic Review and Meta-Analysis. It was published in JAMA Psychiatry in March of 2022. Sorry. So the disclosures, it was funded by Canada First Research Excellence Fund at McGill University. The author does have a few conflict of interest, which they did disclose, sorry. One of the authors is a co-developer of the training, and there were other conflict of interest, but not related to this research article. We'll start off with just kind of reviewing some of the basics of schizophrenia. We're all pretty aware of it, but, just kind of to review it and refresh our memories. As per DSM-5, schizophrenia is diagnosed when you have 2 or more of the 5 symptoms, at least one being either delusions, hallucinations, or disorganized speech. These symptoms should last for a significant portion of a 1-month period and persist for 6 months continuously. And they should affect at least one major area of functioning, such as work, interpersonal relationships, or self-care. The main 5 symptoms are delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. There are multiple theories of the etiopathogenesis of schizophrenia, but the most widely accepted one is dysfunctional dopamine tracts, leading to disturbance in the prefrontal and limbic systems. The tracts which are affected are the mesolimbic tract, which is related to emotional processing and leads to the positive symptoms. The mesocortical tract, which is related to executive functioning and leads to the negative symptoms. There's the nigrostriatal tract, which regulates extrapyramidal movements, and the tuberoinfundibular tract, which regulates prolactin release. These two are responsible for the side effects of majority of the antipsychotic medications. So kind of coming into metacognitive training, so what exactly is metacognitive training? It's an intervention which is based on the theoretical principles of cognitive behavior therapy, but focuses primarily on problematic thinking styles or cognitive biases. The ones which are common to psychosis are, for example, jumping to conclusions, belief in flexibility, and overconfidence in judgments. They're hypothesized to contribute to the formation as well as the maintenance of positive symptoms, particularly delusions. So metacognitive training combines psychoeducation, cognitive bias modification, and strategy teaching. It's generally a really brief intervention consisting of 8 to 10 modules, and it can be delivered both as a group or individual format. The materials are culturally sensitive and easily accessible at low costs. They're presented as flexibly manualized slides, which minimizes preparation and increases accessibility for less experienced facilitators. So these are kind of the core modules of the training itself. To the left are the core modules, and to the right are the domains which it targets. So the core modules are attribution, jumping to conclusion, changing beliefs, empathize, memory, mood, self-esteem, and stigma. So we'll kind of dive a little bit deeper into one of them to get a basic understanding about how this training works. So for attribution, the target domain is attributional bias and monocausal inferences. The first task which is performed is the participants are familiarized with extreme attributional styles and their possible social consequences. For example, blaming others for failure may trigger interpersonal tension. So the participants are encouraged to come up with more objective and balanced explanations for each scenario. Example, sharing success with others instead of praising oneself. And then in the second part of the task, the participants are asked to generate possible explanations for specific situations, such as why a friend has not called them, which would be a negative situation, or why someone invited them for dinner, which would be a positive situation. The objective is to encourage participants to generate explanations for different situations by considering three possible sources, which are oneself, others, and situational factors. And the objective is not to lead the participants to a definitive answer, but rather different possibilities should be contemplated, which helps to change dysfunctional attributional patterns. So the table is just kind of an example of the modules based on the training itself. Coming back to the article has two main objectives. The first one is to review the immediate and sustained outcomes associated with the training with various outcomes. And the second one is to assess the treatment and participant-related mediators in the training. So like every other high-quality systematic review and meta-analysis, the protocol was registered in Prospero and they followed the PRISMA guidelines. They searched 11 electronic databases from 2011 through June of 2021, and they identified 43 studies which were included. So they included participants who had a diagnosis of schizophrenia, and they had to administer either the original version or adaptations of the metacognitive training for psychosis. There were no sex, gender, race, ethnicity, or age restrictions, and they did not have any language restrictions or restrictions based on the study design. The outcomes were organized in a proximal distal framework. The proximal outcomes include those directly targeted by the training. These are global positive symptoms, delusions, hallucinations, and cognitive biases, whereas the distal outcomes are those not directly targeted by the training, but may be either directly or indirectly associated with improvement of the proximal outcomes. These include self-esteem, negative symptoms, quality of life, well-being, social and global functioning. So for the quality assessment, synthesis and procedure, this is kind of a little bit more technical, going into the statistical aspect of it. I'm just going to mention it. We're not going to dive too deep into it. But for the biases, the two authors independently assessed study risk using mixed method appraisal tool. The outcomes was synthesized using comprehensive meta-analysis, and to conduct the meta-analysis, they use Hedges G effect size values. For the moderator analysis, there were the categorical variables were analyzed using subgroup and Q statistics, whereas for continuous variables, they used meta-regression analysis. So kind of coming to the results of the study, so they had a total of 43 studies. Out of them, 30 were randomized controlled trials, 11 were non-randomized controlled trials, and 2 of them were quantitative descriptive studies. The table to the right kind of gives you a little bit more information about the participant characteristics, and it tells you the mean. So the mean age was around 37 years. The mean duration of illness was 13 years. They gave us the Thorazine equivalent dose, which was the mean being around 464. There were slightly more male participants, 63% being males, and around 95% of the patients were diagnosed as schizophrenia spectrum and 5 as other psychotic disorders. So this figure represents the immediate outcomes of the metacognitive training. To the right are blue squares, and the sizes of the square represent the weight of the standard error of the effect size. So more precise the study, larger will be the square. So you can observe that there's a small to moderate effect size of 0.39 for global proximal outcomes. And then when analyzed separately, the largest effect size of 0.69 was obtained for delusions, whereas hallucinations and cognitive biases have a small effect size. So similarly, a small to moderate effect size of 0.32 was observed for global distal outcomes. And then on analyzing them separately, there was a small but significant effect size on self-esteem, 0.17, negative symptoms, 0.23, and functioning, 0.41. Quality of life had a small but non-significant effect size, which is right here. All right. Statistics is definitely not my strongest suit, and every time I kind of see these big graphs and figures, it kind of makes me pretty anxious. But I think kind of getting a basic understanding of these things helps us critique literature a little bit better. So what we see here is a forest plot, and you see little blue squares, and at the bottom there is a green diamond. And then there's a vertical line, which is the y-axis, which is dividing the x-axis to the left of the vertical line, negatives, and to the right of the vertical line is the positives. So these are the proximal outcome effect size for each article separately, which are the boxes. And then I think the most important thing to kind of understand is the diamond at the bottom, which is to the right of the vertical line, which means that it's kind of in the positive side. So which depicts that it favors the training rather than control. Similarly, for the distal outcomes as a whole, you can see all the boxes, which are the individual effect size for each article, and then the diamond to the bottom, which is to the right of the vertical line, which is in the positive side, so that it favors metacognitive training for psychosis rather than control. For maintenance effectiveness, they did see the patients for a 1-year follow-up, and they noticed that all the outcomes were small and non-significant effect size for change over time, which basically means that the effects were sustained in the 1-year period. And then coming to moderator analysis, the only significant moderator was year of publication, which was observed for hallucination. So larger the effect size values were reported in more recently published reports, is basically kind of what it means. Finally, coming to like the key findings and how we can implement this information, given the persistent and debilitating nature of positive symptoms, the training shows great evidence for lowering delusions and hallucinations. There's improvement in distal outcomes, which is a novel finding, and the study depicted small but yet significant and sustained effects on the negative symptoms, which plays a vital role in improving functioning. The maintenance of treatment gains is critical in the long-term functioning of individuals with severe mental illness. Most of these individuals are followed up in the public health system and often have limited personal resources to access private sector services. So supporting the treatment gains of this training has a pragmatic implication for care management. Cognitive behavior therapy for psychosis and cognitive remediation are two well-established interventions which are already used for psychosis. The effect size of metacognitive training for psychosis is similar to the above two mentioned. However, metacognitive training is a short intervention consisting of 8 to 10 sessions. The modules are freely accessible and culturally sensitive. It can be flexibly delivered by less experienced facilitators at minimal cost, which ultimately leads to a broader implementation. The strengths of this study, as mentioned by the authors, are it's a comprehensive study evaluating more than 14 years of evidence. There's novel data in assessing distal outcomes, which highlights the apparent benefit of the intervention on negative symptoms, self-esteem, and functioning. It has a robust methodology and results, and it addresses a lot of, meta-analytical inconsistencies which have been reported in previous studies. The limitations of the study are there was significant heterogeneity of the effect size values for studies assessing global positive symptoms, delusions, quality of life, and functioning, although this was not evident on follow-up. So for the future implications of this study, it has been observed to help with borderline personality disorder, depression, and obsessive compulsive disorder. So kind of trying a transdiagnostic approach, I guess, would be the next step. And with telehealth on the rise, it would be useful for future work to assess the feasibility, accessibility, and effectiveness of the training for virtually delivered interventions. Kind of my critical analysis of this article as a whole. So based on the objective, I think it was really clinically relevant. It asks a clear, focused questions. The outcomes were examined quantitatively and qualitatively from pre-intervention to post-intervention and follow-up, and it identifies a gap in the literature. For the methodology and analysis, it uses a standardized framework and standardized scales. There's explicit and rigorous literature search. There are predefined inclusion criteria. It tested for statistical heterogeneity using subgroup analysis, and it also evaluated for publication bias. For the results and implications, the rigorous quality of reporting includes interpretation of data, including implications for clinical practice and future research. But however, there were definitely a few things which I was curious about towards the end of the article, and they didn't really shed too much light on it. I think these are important as a clinician. They didn't really mention the severity of illness. For example, they did say that they had done the PANSS score for positive symptoms, but they didn't give us more detail or insight into what the score was, what was the main score, how severe the illness was. Another thing which I thought about was, were the patients treatment resistant? How many medications were they on? Did they undergo any procedures like electroconvulsive therapy? Were there some groups of patients for whom the intervention was more effective compared to others? I think kind of getting more insight into the participant characteristics and diving a little deeper into that as a clinician, I feel would give us a better understanding of the training and when to use it, and for which group particularly. Also, another question which I had was, they did follow up patients for a 1-year period, but after that here, would they need a booster training? How long does this training actually last? And I feel like these are things which were not really mentioned, and what I thought would be important to know as a physician. So any questions or comments? I think we can kind of open the panel, and if anyone wants to share anything, I think this would be a good time. Let me stop sharing my screen.
Oh, hi, Bhumika. This is Catherine. First off, thank you so much for doing that journal article. I think it's really interesting. It kind of reminds me of, back in the day when, medications weren't something that we had to help our patients. Therapy was really the one and only way that they could try and treat their patients. So I think it's nice that we're kind of seeing that come back in a more modern way. My question, and I'm sorry if you already mentioned this or if it's already included in the paper, but I was wondering, with having these patients involved in therapy, gaining that insight, cognitively, it sounds like it could be very helpful, especially with the chronic nature of this disease, right? So I was just wondering, was there any sort of objective study on the cognitive assessments for these patients? Was that ever tracked, or do you think that's something that should be tracked in the future?
Yeah, definitely. I agree with a lot of the things that you said, that how therapy is kind of coming back, and it's for cognitive tracking. I think I went through most of the articles and I personally couldn't see anything which they tracked. I think it would be something which would be really, really helpful in the future to kind of work on this. This is definitely kind of newer and upcoming. There haven't done too much about this. So I think there's a lot of scope for it.
One thing I liked about your talk, particularly Dr. Shah, was that this was something you could theoretically take to the clinic tomorrow or this afternoon. Maybe not all of it, maybe not the whole thing, but it was a little something that has some practical value. It's not just some research paper somewhere. Also, you seem so comfortable. This is like you've been doing this all your life.
Oh, thank you, Dr. Lipman. I really appreciate your comments. I think Ali has his hand raised.
Yes, Bhumika, thank you so much for doing this. I think that was very helpful. That was very, informative that you did. I do have one question though. So when we see these effect sizes, we saw that the largest effect sizes in the study was for delusions. So what are these delusions like? Purely for the delusional disorder, or were they part of the like MDD with psychosis or schizophrenia? Or if you could comment on that a little bit, that would be great.
Yeah, definitely. That's a really good question. So the participants which were included were either diagnosed as schizophrenia or schizophrenia spectrum disorder. So I don't think MDD was one of the, the kind of patients with psychosis would be one of the patients. I think 95% were diagnosed with schizophrenia itself. And then there were 5 which were, in the spectrum, other psychotic disorders. So that's kind of how the breakdown is. I hope that answers your question.
Yeah, thank you. It does.
So something interesting I noticed about the effect sizes in that the proximal outcomes, positive symptoms, and delusions had the highest effect size or the best effect size. If you look at the actual supplemental forest plots, there's one study in particular, it's Irawadi's study. They only measured those 3 things. They didn't measure the rest of the things. But if you look at the forest plot for them, they're kind of off the charts on the right. Like they must have the best therapist ever. So I know I'm wondering like how much of this is actually, due to this type of therapy thing, or is this like just Irawadi really took the show and made it look really good, much better than it actually is?
Yeah, that's kind of an interesting thing, because the person who delivers it also kind of plays a big role in it. I'm sure there are a lot of confounding factors, but I don't think they've specifically mentioned anything which I recall while reading the papers, as well as the articles which it analyzed. But I'm sure there are definitely a lot of confounding factors in this training.
Yeah, it's also interesting when they talk about past meta-analysis that has been done for this metacognitive training. They mentioned that when the studies that are put into the meta-analysis, when they're restricted, all of a sudden the effect size goes away. So I don't know if that's because those studies or those meta-analyses are looking at studies that appear to actually have like real psychosis versus, psychosis. Like, are we treating psychosis or are we treating psychosis? And so like the other studies maybe have more personality disorders in them, or maybe more cultural things that are like psychotic like, but not actually psychosis itself. And then they also comment like when you add in Eastern studies, when you look more like Eastern studies than Western studies, then you have a better effect size as well. So there's definitely something cultural going on, or something different in how we diagnose schizophrenia amongst different countries, or maybe it just works on a certain subset of demographics than others.
Yeah, I think that those are really interesting comments which you brought up. I guess only more research on this will kind of tell, and time will tell. Megan, do you have a question or a comment by any chance?
I guess you're talking to me. Did I have my hand raised or?
We're in the panelists. Never mind. Sorry.
No. I mean, I can speak to this a little bit. Just this is completely subjectively, so just take this as you will. But a lot of my sister has schizophrenia, and one of the things that has benefited her most has been therapy, specifically cognitive behavioral therapy. It's taught her to recognize her delusions, to recognize when things are, what the possibility of something being psychosis versus not psychosis. And it's also taught her to calm herself down in triggering social situations where she might get paranoid, like in public. So I think there's sort of this, and I'm not saying in our program necessarily, but I think overall in psychiatry, there's an attitude that people with psychotic disorders can't benefit from behavioral treatment. And I would thoroughly disagree with that. I think it's one of the best things you can do for this patient population.
Thank you so much for sharing that, Megan. I definitely feel, especially in schizophrenia, how we have like our cognitive decline and problems with cognition. This training is so easy, which is why I kind of went into like a little bit about one of the main modules, but it's so easy to do. It's so simple. And, just these 8 or 10 sessions, it doesn't even have to be delivered by a psychiatrist. It can be someone who's less experienced, and they have trainings for that in case someone who wants to not very well familiar with schizophrenia or psychosis, they can undergo a training and then deliver this. And if such a brief intervention can, help patients and people, especially with negative symptoms, I think it's definitely something to keep in mind. Any other comments or questions?
Yeah, I was thinking about that sort of reinforces to me, just a second, let me see if I can get well, I don't know, anyway. It reinforces the importance of the doctor-patient relationship. And I think that is underplayed in our field, and certainly in the rest of medicine. The importance of the doctor, if you tell a patient to do something and they don't like you, you might as well whisper it in a foreign language. It is not going to make any difference. They'll nod their head and say, yes, doctor. And if you don't have that relationship, they don't do what I figure in my life, as having been a doctor now for 5 decades, if you tell somebody to do something, they do 50% of it. So if they don't like you, they're going to do less. So anyway, that's so be it. Thank you. You did great. And I like that you fielded the questions very comfortably. It just was natural for you. Good show.
Thank you, Dr. Lipman. Any other questions or comments before we can kind of end? We'll just give it a minute if anyone has any questions or comments.
Just some more. It's a very interesting topic, using therapy in psychosis. And to go on what Megan says, I certainly don't think it's detrimental in any way. I certainly think it definitely helps some people, for sure. Some people greatly. But when in the past, before we had, say, Thorazine or penicillin, there are a lot of people institutionalized in psychiatric hospitals, and all we really had was therapy. And so many patients there were psychotic until medications came along. So I do think that therapy probably helps in some patients, maybe some of the more higher functioning patients than others. But I think that there's also a lot to be said about the combination of medication and therapy. That's just my comment.
Yeah, definitely. I feel like the combination would be something which could be possibly used in the future or right now. I feel like just a little bit more research needs to be done on that and using it in actual people and observing long-term.
Yeah, to be clear, Dr. Reif, I wasn't saying that we should use therapy without the absence of medication, to make that very clear. But yeah, good job, Bhumika, you did great.
All right, anybody else has any other questions? Thank you, Dr. Shah.